Well, today we are in session 334 entitled Non-Surgical Treatment Options for Primary PTC. Patients share their experience with radiofrequency ablation. Thank you for joining us this afternoon. My name is Jennifer Holkem. I'm a thyroid patient advocate and educator and the founder of Save Your Thyroid, a private Facebook community and future nonprofit organization for patients pursuing non-surgical treatment options for thyroid nodules. In 2019, I was searching for an alternative to surgery for my own thyroid nodules and discovered radiofrequency ablation. And due to a severe lack of patient-oriented resources on this and other thermal ablation procedures, I created my own YouTube channel, It's Me Jen Again, where I share my own experience and create educational video content on this topic. I'm a passionate educator and advocate for patients and doctors to save the thyroid when possible. Also, just a friendly reminder that this information presented in this webinar is in no way a substitute for consulting a medical professional. It is purely for educational purposes only. Now I'd like to introduce Dr. Ralph Tufano, our guest speaker. Dr. Tufano is an otolaryngologist at Sarasota Memorial Health System in Sarasota, Florida. He is also the medical director of head and neck endocrine surgery at Sarasota Memorial's First Physicians Group Thyroid and Parathyroid Center. Dr. Tufano specializes in thyroid and parathyroid surgery, including the management of hyperparathyroidism, thyroid nodules, early, advanced, and recurrent thyroid cancer, neck lymph node metastases, goiter, and Graves' disease. His expertise in novel treatment techniques have helped personalize treatment and improve surgical outcomes for patients with these conditions. From 2009 to 2015, he directed the Johns Hopkins Hospital Multidisciplinary Thyroid Tumor Center. And also joining us today, we have two patients, Jody and Marina, who will also share their stories. And if time allows, we will show a pre-recorded testimonial from one additional patient named M. So I'd like to start the session by having Dr. Tufano give us a brief explanation of radiofrequency ablation and how it can be used to treat thyroid cancer. Dr. Tufano.
Hey, Jen, thank you very much. I think this is a great session, and I'm really excited to speak a little bit about radiofrequency ablation, sort of the new kid on the block here, right? Because, we talk about sometimes the different types of surgery that have been the standard treatment for, taking care of thyroid cancer. And, we've popularized some remote access approaches and things to sort of improve on certain quality of life issues that can come about with surgery. Certainly the scarless transoral surgery is one of them to avoid a neck scar. But those are just other ways of doing surgery. It's not really transformational or disruptive. The fact that you can actually avoid a surgery and avoid a general anesthesia and all the possible consequences that typically come with that, including the risk of, having surgery, and then also the possible need for thyroid hormone. Well, if you can do something in your office under local anesthesia in a very short period of time and treat that thyroid cancer effectively with very minimal side effect profile, and that's disruptive. That's a change. It's transformational. So I'm really excited about these new ablative technologies, and RFE being the one that we're using now. So think about it. When you go ahead and you have your evaluation, you typically see a doctor, an endocrinologist, a surgeon, a primary care physician. They identify the thyroid nodule. And then on ultrasound, when you get that, there's a concern for possible cancer. So you go ahead and you get your needle biopsy. And that's not necessarily a fun procedure, obviously, but nonetheless, absolutely necessary to make a determination about what you're going to do next for that nodule. Now, in these situations, when we think about whether we have a benign process or maybe even a small malignancy, we can think about the possibility now of doing something very similar, very akin to what you had in your fine needle aspiration biopsy, right? So this is an office setting procedure where you're very similar to a fine needle aspiration biopsy. You're placed on a very comfortable chair or bed to essentially lie flat with a little bit of gentle neck extension. And similar to the fine needle aspiration biopsy, we're going to take a needle that at the end, we're allowed to heat it, right? So it's a heated element at the end of the needle, such that when we allow energy to go through that needle, it's really actually cooking the tissue, so to speak. We have what is known as in pathology a coagulation necrosis. So that tissue is heated up to the point where it's devitalized, and it's not going to come back if we treat it effectively. So again, with a little bit of numbing medicine that we place over the thyroid, and typically just like your dentists use as a Novocaine, we'll use a lidocaine. And we'll go ahead with ultrasound to visualize where our nodule is and our target, and then use our needle to get to that nodule. And then with the help of a generator supplying energy through this, the radio frequency waves heat the tissue up to the point where it boils it or cooks it. And then a coagulation necrosis occurs where over time, the body's own system, right, the own immune system starts to heal and fibrose and get rid of that area of injury, of injured tissue. So that's really what RFA is in its most simplistic form. And we are creating heat. We're putting a lot of heat in that nodule. We're actually boiling that tissue to the point where we're coagulating it. And we hope that it will completely become non-viable and disappear. That's what should happen if we do it effectively.
And a big advantage of this procedure, Dr. Tufano, would you say is the fact that the rest of the thyroid is left intact and that the patient does not need any further hormone treatment?
Yeah, I mean, so that's a huge, impact, right, for the patient. I think that, how many times have we been asked, or you ask, in fact, why are we talking about taking out half of the thyroid or all of the thyroid? Why can't you just treat the nodule? So in the right circumstances where there's a small thyroid cancer, a differentiated thyroid cancer, most commonly papillary thyroid cancer, and there are no other concerning features, and there are not a lot of little spots that could be thyroid cancer, and the lymph nodes are okay, then why not just treat that one area and continue to follow with ultrasound like we typically do even if we do surgery, right? And so the benefit of not touching the rest of the thyroid is that you'll have little, if any, disturbance in your thyroid function. So it's a very low likelihood that you would need anything, especially if you're treating a small thyroid cancer, need any thyroid hormone supplement at all.
That was an excellent explanation. Thank you, Dr. Tufano. I would like to introduce now our first patient speaker, Jody, who is a member of the Save Your Thyroid Facebook community, and she underwent thyroid RFA at the Mayo Clinic for her small papillary thyroid cancer. Jody, would you share your story with us, please?
Thanks, Jen. Hello, everyone. I had radiofrequency ablation, or RFA, at Mayo Clinic in Rochester in November of 2020 as part of a small clinical trial using RFA on small papillary thyroid cancer. My nodule with papillary cancer was found incidentally on an MRI of my cervical spine in February of 2019. The nodule measured 1.5 centimeters on the MRI, though later on an ultrasound it only measured 0.8 centimeters. I went in for an ultrasound and FNA in March of 2019. The nodule came back suspicious for papillary thyroid cancer. Then a month later, I saw an endocrinologist at Mayo Clinic in Rochester, and they also repeated the ultrasound and reviewed the pathology slides. On the ultrasound, the nodule appeared solid, hypoechoic, not taller than wide, with irregular margins and nondescript echogenic foci. They agreed on the papillary thyroid diagnosis and recommended surgery, but I chose to wait and watch the nodule. At that time, the nodule was quite small still, 0.8 by 0.5 by 0.6. Then I went back in September of 2019. It was just a tiny bit bigger, it was about 0.9 centimeters, and then again in July of 2020. And at that point, it was 1.2, so I'd grown just a tiny bit. In September of 2019, my endocrinologist told me about the possibility of ethanol ablation. I asked more about that option on my return visit in July of 2020 and was informed the nodule was now too big. I was frustrated and definitely liked the idea of a non-surgical approach, and so the endocrinologist reached out to Dr. Robert Lee in radiology to see if ethanol ablation would still be an option for my case. And through that conversation, I learned about the clinical trial for RFA that Dr. Maria Stan is heading up there. A few conversations, appointments later, and I was signed up for the trial. There was a bit of concern during the vetting process about the location of my nodule. It was close to a carotid artery, but they were able to use hydrodisplacement during the procedure to create space to safely ablate the nodule. The procedure itself took place on November 6, 2020, under the hands of Dr. John J. Smits, a doctor in radiology there. Since I was put under general anesthesia, which I know is kind of unique and not normally used, I didn't have to worry about the procedure itself becoming too uncomfortable, but I did have a hard time waking up from the anesthesia. It also temporarily stunned my bladder, which I've had happen in the previous surgery anesthesia situation. I remember arriving pretty early in the morning and not leaving until maybe noon or a little after, I think in large part due to the time it took to wake up and recover from the anesthesia. So I was there a good half day. Afterwards, my neck was quite tender and sore, and I had a sore throat. I felt extra tired for at least a week or more and had a decent looking bruise. But overall, I would say the experience wasn't bad at all. Initially, my TSH dropped a bit right afterwards, and my free T4 was higher due to a release of thyroid hormones from the procedure. Then for at least a few months, I actually had a little bit of a high TSH, but since then the numbers have stabilized. I've actually seen thyroid globulin antibodies slowly go from a bit high to normal in the last couple of years, and thyroid globulin has always been in the normal range, but that number has also come down. I have had 5 follow-up appointments since having RFA. Initially, the nodule measured larger since they ablated the perimeter of the nodule to make sure they get all of the cancer, and also due to the inflammation in the healing process. On 2/8/21, the nodule measured 1.4 by 1.3 by 2.1 centimeters. For reference, at the time of RFA, it was up to like 1.1, 1.2, so quite a bit bigger 3 months post RFA. But at my most recent appointment just last month, the nodule measured just under 3 by 3 by 2 millimeter, so it's pretty small and hard to find. On follow-up ultrasounds, there's been no internal vascularity and no spread within the thyroid or lymph nodes. I do have a number of other small thyroid nodules that we have been watching as well. I am hoping none of them become a problem in the future, but if they do, I can consider RFA or surgery as needed. I have been treated in the past with many months of antibiotics for Lyme disease, and I continue to have a number of symptoms, perhaps related or unrelated, but I would say I maybe function at 70% of normal. I know many people do just fine on thyroid hormones, but not everyone does. The thought that perhaps my body would struggle even more if my thyroid was half or completely removed was not a thought I wanted to entertain, unless it became really apparent that I needed to take that risk. Also of note, I got married about 2 weeks before having RFA at the age of 37, and then about 3 months post RFA, we started trying to get pregnant. I got pregnant about 7 months post RFA, and then in March of this year, I gave birth to a full-term, beautiful, healthy baby girl. During the pregnancy, my thyroid levels were checked monthly because I have had some risk factors for becoming hypothyroid, but my thyroid levels were good and stable throughout the pregnancy. And lastly, the clinical trial I am in is for papillary nodules under 1.5 centimeter, but I have heard recently that Dr. Maria Stan is not treating papillary nodules over 1 centimeter now. And that is all I have. I just want to thank you for letting me share my experience, and for everyone who worked at putting on the conference this weekend.
Thank you, Jody. That was a very in-depth description of your experience, and I really appreciate you sharing all those details. It was very helpful in understanding, and I'm so glad that so far you're doing well since your treatment.
Yes, I am too.
Awesome. All right, well, next I'd like to introduce our other patient speaker, Marina, who is also a member of the Save Your Thyroid patient community, and she underwent RFA treatment for her small papillary cancer in Newport Beach, California with Dr. Sean Nickravon. Marina?
Yes. Hello, everyone. I wanted to share my experience with RFA. First of all, Jennifer, I'm so grateful for you and for all the ladies that organized this wonderful group. That was my resource for finding all the information about RFA and other procedures to treat all kinds of nodules. My nodule was discovered incidentally, like most nodules are, on an MRI for unrelated to thyroid tissue. And I underwent biopsy. It was highly suspicious for PTC, and I wanted to see what options I had for treating the nodule All the conventional doctors said, no, you have no options. Your only option is to undergo thyroidectomy. And I was just dreading it. I did not want to accept it. I was willing to fly to the moon and back just to save my thyroid. Luckily, because of the group that Jennifer organized, I was able to find doctors that were able to give me some information. I was lucky enough to find Dr. Nickervan, who is located in Newport Beach, California, who is a very brave clinician. At the time of my visit, my nodule was 1.36 centimeters, which is, I believe, the largest cancerous nodule in US that was treated with RFA. In any case, my RFA took place on May 29th of 2021. I had minimal discomfort, really no side effects at all, minimal bruising, minimal scarring. It was easy peasy. And I had follow-up ultrasounds and blood tests, and all my measurements were just great. My thyroid levels were optimal. I never had any issues with my thyroid function. I did have another RFA treatment recently, about 3 months ago, because of some residual blood supply to the nodule. That went really well. At this point, my nodule measures 0.5 centimeters, which is a great reduction. It's completely avascular. It's considered to be completely dead tissue. And Dr. Nickervan hopes that eventually my body will just dissolve all that scar tissue. And once again, I'm super grateful for all the work that you do, Jennifer, and for combining all the resources and hopefully saving more thyroids. For me, RFA was an amazing experience, and I highly recommend for all patients to explore that option. Do everything possible to save your thyroid. So that's my story.
Thank you, Marina. I really appreciate
Thank you, Jennifer.
All right. One more patient story we're going to share is actually a video recording. This is M. She's from the UK.
I started feeling really unwell and life was just so busy. I'd go to the doctor for the occasional blood test. They'd say, look, it's all clear, you're fine. I had some other chronic health conditions like endometriosis and some other things. So I just put it down to that. And then obviously when we were all in lockdown, I had time to focus. It's time to really look into what tests haven't been done. So I asked my doctor for a list of all my bloods. I went through them and slowly but surely I saw that my calcium had been repeatedly high over years, maybe 2 or 3 years. My doctor at this time was saying, you know, I'm having loads of patients at the moment that have health anxiety. This is what's coming out from the pandemic. You know, I really believe that that's what's going on for you. Luckily, because I'd asked for my results and I saw this repeated high calcium, I realized there was definitely something up. And I found out about hyperparathyroidism. I actually paid privately because obviously in the UK we have the NHS, got a scan of my thyroid and my parathyroid. They said, oh, there's an unusual lymph node going on there, but they didn't think to check it out. But they said, look, yeah, you've got a tumor on your parathyroid. We need to get that out. Went off to find this other amazing endocrinologist up in Oxford. He did the surgery, and that's where he found a black lymph node during my surgery. And within a week, he'd called me up and said, sorry to let you know that you've got thyroid cancer. Part of the reason why I sacked my previous endocrinologist was that he had seen the lymph node, but he was just determined to get this parathyroid tumor out. He didn't biopsy the nodules in my thyroid. He said, oh yeah, you've got some nodules. But as it happens, I had on the left-hand side one that was as big as 3.4 centimeters. And on the right, I had 5 nodules. And on the right-hand side, I had the papillary thyroid cancer. I just knew my body and I knew there was something not right. So I just thought, I'm going to keep pushing for answers. I know there's something out of balance here. I went and had biopsies, and in England, normally if it's under 1 centimeter, they don't tend to biopsy, right. But they knew from the lymph node that they had to biopsy all of those ones, and we didn't know if it was in the left or right. Lymph node was found in the right-hand side, but they did the biopsy on all of them, because some of them were as small as 2 millimeters. And the one that they actually found the papillary thyroid cancer in was 4 millimeters. Some of them came back atypical. So on the left-hand side, my larger one, which has now gone from 3.4 to 1.1, did come back as atypical cells. So there is a chance it could be follicular. but there's a kind of 10 to 20% chance.
Did you have genetic testing done to determine that?
Did have the genetic testing to make sure I didn't have the BRCA.
BRAF, I think is what
BRAF, that's it. Yeah, BRAF.
I don't know in the UK what these companies are. In the US, there's ThyroSeq and there's a Afirma testing that they can do to determine a percentage of risk of cancer. So like when you said 20 to 30% risk of cancer, it made me wonder if that was the same type of testing.
Just my endocrinologist said, you know, depending on how it looks and how it responds, and he said from the atypical cells, they just give you a rough estimate, and that's usually anything between 10% and 30%.
It sounds like maybe what he's referring to is the Bethesda categories, maybe, which is basically how it looks on ultrasound. What are the qualities of it? You know, the shape, size, is it smooth around the outside? So once you've had an RFA treatment, those were treated with RFA, correct?
Yes, all of them were.
Okay. So once you've had an RFA treatment, the nodule may have started off as this very smooth, lighter gray color. And once you treat it with heat, think about if you use a wood burning tool, what happens to that wood? It gets dark. It may lose its smoothness. It may get irregular. It may get a funny shape as it starts to shrink and draw in on itself. For example, for my nodules, when I had my follow-up ultrasound, they looked like cancer after they had been ablated.
Oh, wow.
And so if I were to go to a doctor who does not know that I've had RFA, they would be very concerned by looking at my nodules. My provider, who actually did the RFA, who knows what it looked like before, he knows that it was confirmed benign by 2 biopsies. We know that it's not changed just because of the RFA. And so that's why annual follow-up is important. And you'll have continued follow-up to see if there are changes, because if your nodules suddenly start growing, you know, okay, the cancer is growing and maybe you need to consider surgery at that point.
Yeah.
If it continues shrinking and if there are no changes that increase in size, you're in good shape. Going back to what you were saying, sounds to me like he was just evaluating your nodules based on their visible appearance on ultrasound.
Exactly. Yeah.
So, and it still sounded like it was favorable.
Yeah. And the fact that it's had, you know, a good amount of shrinkage since a year ago when I had my RFA to now, so it's gone down to 1.1. He said, you know, it's promising because the last time we tested, we've done 2 scans since the RFA. So right after, about a month after RFA and 6 months later, and then on Monday, he said, you know, it's looking amazing. There's literally no scar tissue at all on the right-hand side whatsoever, and that was 5 nodules done. I'm over the moon to have found RFA. I am so glad, because the last thing I wanted when I found out, you know, the options were, you're going to have a thyroidectomy and then you're going to have radioactive iodine. And I thought, firstly, I have a son that needs me around. Thought of not being around for my kids, isolating for 30 days, possibly for 2 rounds. I just thought, I just don't want to do this. So I was so glad for the pandemic. So I had all this time on my hands to research all the options available to me. The problem I had was because it had spread into one of my lymph nodes, no one wanted to treat me, because they said, really, it's too tricky, you know, you're not really a candidate for RFA. But I knew that my lymph nodes were looking good. You know, I'd had that black one removed. Luckily, Dr. Caucasus was the only person that would take me on. I think I emailed maybe 8 different doctors around the world. And then I saw your interview. Who's the Canadian guy?
Cyrus.
Yeah, Cyrus.
Yeah.
And I was like, oh my goodness, our stories are so similar.
He had a very small papillary cancer, and he said it was completely gone afterwards. And that's just amazing.
Yeah. I mean, my 4mm one was completely gone. All the right-hand side, everything was gone straight away. If this one on the left-hand side does grow, I will go back to have radiofrequency ablation again, because I've seen how easy and effective it is. You know, the fact that you don't even have to have an anesthetic. You lie down on the table, they do it, and you get up. And, you know, in my case, I flew home. It's just amazing.
What you're dealing with was kind of outside of the normal boundaries of what is typically treated with RFA in cancer cases. The fact that that lymph node that you had that was black was surgically removed when you had the parathyroid surgery, I wonder if maybe that is reason for Dr. Caucasus taking you as a patient for RFA, because knowing that that was surgically removed, you do probably have some scar tissue from that surgery, a subsequent surgery, a little bit difficult.
Exactly.
It also means that that lymph node was completely eliminated. I mean, there's always a risk for microscopic spread with surgery.
Yeah.
Why you need the follow-ups, but it's gone. It's not still there, potentially going to grow. And so, you know, there's a little bit more of a definitive situation with what you have than someone who has never had a neck surgery before.
It was a bigger risk than most people that have RFA for thyroid cancer, and I was willing to take that on. I knew the consequences would be that maybe I would have to have a thyroidectomy with radioactive iodine, but I thought, if it gives me a little bit more time, a year to 5 years, I'll be really happy with that. And as it happens, I feel really hopeful.
Yes, the biggest benefit of RFA in these kinds of situations is that it is not burning a bridge. It's not permanent in the sense that you can't have a surgery afterwards. It's not a choice between one or the other. It's just another step in that road that you may not go past that step, but if you need to, you can. This is exciting. I'm glad you're doing so well. Now that we've gone through all these testimonials, I would like to see Dr. Tufano. Do you have any comments you'd like to make on what we've heard so far?
Yeah, I do. I think that all over the world, the management of thyroid cancer, especially differentiated thyroid cancer, despite our guidelines that are present for best practice, are certainly different because of resources and the way cultures are and the way we interact with our patients. As you heard in the last story, the national health system provides a certain set of challenges that are difficult to deal with compared to our health system in the United States, and some of the challenges that we have, they don't have. So you have to take each case and really think about personalization of each case. And with that being said, it really comes down sort of to a team and being open-minded. And I usually show a slide at every presentation where I have the pathologist, I have this patient at the top, and then the surgeon, the endocrinologist, and the pathologist all working together, but the patient is always at the forefront at the top, thinking about what are the best options for the patient and letting them make their value-based decision. I would say that when we're dealing with thyroid cancer and we're thinking about using radiofrequency ablation, the best data that we have is from our colleagues in China and in Korea. And they are usually treating small papillary thyroid cancers in favorable locations in the absence of any other concerning features. So very specific to these low risk tumors. Now, when we talk about treating benign nodules with RFA, boy, we can treat anything almost now, big nodules, everything, but we're not having to get the nodule to go away completely. If thyroid cancer, we're not accomplishing that, we might as well be watching it, right? And we do have active surveillance for small thyroid cancer. So we have to be cognizant of, are we using this as something temporizing? Are we just placating the patient, making them feel better? Or are we really affecting a cure? So I want everybody to kind of understand that for right now, what we could all agree upon is that for these smaller papillary thyroid cancers, and I do agree that we're going to be able to move the needle toward papillary thyroid cancers that are even 1.5, 2 centimeters, for example. But it requires a team approach. It requires very careful patient selection and discussions with the patient to make sure that this is the best option for them. And this is something that they truly understand and desire. And that's important because you really have to have expertise. If you just have somebody who can do the radio frequency and they can be a technician, well, they can target every nodule in your thyroid, cancer or non-cancer, and even lymph nodes, for example. It doesn't mean they understand the disease process, and that doesn't mean that it should be done. So really, again, this is a team approach, everybody working together to understand what's really the best options for the patient and then to put those forward. So I know that there are a lot of questions. And I'm happy to take any of those questions, but I want the group to focus on, we're really early here in this field, right? And I think that when we have a small thyroid cancer, again, papillary thyroid cancer, differentiated thyroid cancer, we're not talking about anything that has any concerning features for something more aggressive. We're not talking about a molecular profile that has a prospect of something more aggressive. We're not talking about medullary thyroid cancer or anything other than garden variety papillary thyroid cancer. We have to prove that in our hands, this is as effective as active surveillance or surgery. And we're still in the very early stages of it. So I think that when we have a small papillary thyroid cancer, and we could consider just surveilling it, and then we can consider something as extreme as surgery. So we have the two extremes. This fits a nice happy medium, right? And it makes sense. But we have to be careful to not think that everything is a nail because we have this new hammer. And that's important.
Thank you, Dr. Tufano. That was an excellent explanation. And with that, I think we'll go into answering some of the questions in the chat. And the first one is actually for you, Dr. Tufano. Can you comment on radiofrequency ablation for someone who's already undergone a thyroid surgery and has new developing tumors or lymph nodes?
Yeah, great question, because I do think that there is a role for treating lymph node metastases, and we haven't really talked about that. But for example, in patients who have had multiple surgeries, and either further surgeries are very, very risky, or the surgeon just says, you know, this is something that's not a good idea, and your team thinks it's not a good idea anymore, but you really would like to have something done. I think that those lymph nodes that are in the lateral compartment of the neck, especially somebody had brought up, and I think before it was Jody who talked about hydrodissection very quickly, you can actually inject either some sugar water, or usually it's sugar water, it's the best medium, to separate that little lymph node of concern or that mass of concern away from the surrounding structures so that you can more safely administer the heat from the needle. And I think that in those certain circumstances, when you say, really, what is further surgery going to accomplish, or further surgery can potentially hurt the patient, in the lateral neck compartment where ethanol has been used, you know, somebody I think even asked a question about ethanol. So alcohol has been used. I think radiofrequency is much better, because ethanol, when it gets outside of the lymph node and it can easily extravasate, or, you know, you may not get it exactly to stay in the lymph node, is very caustic. It causes a lot of fibrosis and scarring. It's actually painful. And it may be even more difficult to treat that patient if they needed surgery. So I like RFA, but it has to be done carefully. And in that kind of patient population, yes. I would say that in the area where the thyroid used to be, we really have to worry, because now if we have something smaller in that very critical area where the trachea, the esophagus, the nerves are, and everything is in a much smaller space, because the thyroid was actually like a spacer between the trachea and the carotid artery. All that is compacted. You don't know exactly where those structures, especially the nerve, the recurrent nerve at that point in time is, and the nerves do not like heat. If you heat up a nerve and it stops functioning, it's not going to come back. So I don't like it for that area where the thyroid used to be. You know, I don't like that area where, you know, you had your thyroid, but now it's in that close area to all those important structures. But in the lateral neck, I think it could be considered in certain circumstances, yes.
Excellent. And do lymph nodes need to be a certain size before having RFA treatment?
So remember, again, at this point in time, and M's story was really interesting. And in the national health system, you know, what happened there, and then she had to go somewhere else to a completely different country to get care. It's interesting, but I'm going to comment on lymph node metastasis. When we start to see lymph node metastasis, we're worried that this tumor may be behaving more aggressively. And sometimes when you have one lymph node, it's only the tip of the iceberg. There are often more lymph nodes involved. And so if you don't intervene to treat all of that, are you missing an opportunity to control that so it never becomes a problem again? So you give yourself the best chance of never dealing with it again. I would say to you that as long as you can see that lymph node on ultrasound and confidently reconcile it, and then all the different structures anatomically around it, that lymph node is targetable and treatable. The question is does it need to be treated? We know that for small lymph node metastasis, just like small papillary thyroid cancers in the thyroid, in the lateral neck, if it's less than a centimeter, we can watch it. I know that may not sound good to some people, right? But it is an option for this monitoring / active surveillance. And the same thing for small lymph nodes in the central compartment where the thyroid used to be, if they're 8 millimeters or less. So I think we always have to think about all the possible options. And yes, small lymph nodes can definitely be targeted with RFA, but is it the right thing to do? We have to see about that.
Exactly. I believe that the recurring theme we had in our session yesterday was that this is a very individualized situation that we're dealing with. It's not an across the board type of statement you can make where it's just any thyroid cancer can be treated with this. It has to be very particular to the patient's situation, their anatomy, their disease process, and the physician's skill level. So thank you for expanding on that.
Yeah, that's a great point, Jen, because it depends on where you go and what your teams are composed of and their expertise. And, you know, it's just like operator dependency in surgery. Not every surgeon is the same. Not every surgeon, even if they say they do thyroid and parathyroid surgery, has the same experience, even with recurrent disease, for example. So you really have to do your homework and try to discern who are the best for those particular situations. And the same thing with ultrasound and RFA. Again, very important. Yeah.
And to that point, I also tell patients often that it's very important if they're pursuing RFA or any other thermal ablation procedure, that they go to a provider who's trained in that procedure, because if they ask any provider who's not trained in it, they may not get an accurate explanation of the use of that procedure or if it's a good fit for them. So that's important.
Absolutely.
Okay.
Yep.
So somebody's asking how many sittings for RFA and cost. I'm going to just say, I think that the patient is asking, is this a repeatable procedure?
Well, we definitely know that for benign nodules, it's very repeatable. And sometimes, as you did, you had to go through it, right, twice. And so people, I know in Korea, they've done it for a lot longer than we have done here in the United States. And they've done it multiple times for some patients. And that's the thing, that you can consider an intervention with RFA, again, if you feel like you haven't achieved your desired result with the first intervention, whether it's the patient or you. I think with the small thyroid cancers, certainly we can consider another intervention if necessary. I don't think that that's too much of an issue. I think Marina underwent that process because, you know, it is challenging. These little nodules, you may just think that you're ablating the parenchyma, and you look at the Doppler signal and you see if the blood vessels are all ablated and there's no more blood supply. But sometimes the vascularity, there's revascularization. And so to be sure, you may want to go back in and actually get some of those vessels if it revascularizes. And so I think that, you know, that's fine as long as that nodule is not growing and there are no lymph nodes manifesting and something more worrisome developing. I think that that's okay to do. And certainly we can do it if necessary. So yes, there's no sort of, you can only do it once or twice. But, you know, it has to make sense in the long run. You know, you don't want to do 20 of them either, though.
No, that might not be very fun. And,
right.
Also not very cost effective. This is
right.
also included in the question is cost.
Exactly.
And
exactly.
I'll just bring up that for this person who's asking the question, it varies dramatically across the country, whether or not it's covered by insurance, and also there are various levels of expense with cash pay. So at this point in time, we are seeing more cases that are for cancer being covered by insurance. But again, it varies depending on your insurance, depending on your state. So that's something I would encourage patients to pursue. As you said, Dr. Tufano, to do their homework and see what you can find out.
Yeah, no, I think that's important because a lot of us realize at different systems and health systems, and whether you're in the private practice arena or you're a part of a big hospital system or an academic system, obviously there are expenses, there's time, and for some, it's not a good business decision. Unfortunately, this comes into play, right? Always. It is, you know, real world. And so they may have to say, well, I'm sorry, we only take we don't take insurance. This is our, you know, our charge, and this is what you have to pay. And then others may say, well, let's see if we can work with insurance and see what we can do to partner together. As more data comes out, you know, certainly that's what we're doing here at Sarasota Memorial in our Thyroid and Parathyroid Center, working with insurance. But as more data comes out and more robust data, it's going to give us a little more leverage and with the insurance companies, and they're going to pay attention to it more and then help cover these interventions. And I think then once they start to cover it, especially some of the major players, they all start to cover it. So that's what we need to have happen. And it's starting with benign disease, yes, more so than small thyroid cancers, because the benign disease is the higher volume of treatments, but I'm hoping that we'll start to see it for small thyroid cancers as well.
And we did have one question about other types of ablation. And in the United States, the only ablations that are available currently are alcohol ablation, radiofrequency ablation, and laser ablation. I do know that in other parts of the world, there is cryoablation and microwave ablation. Do you have any comments on any of those other types of ablation?
Yeah, and even high intensity focused ultrasound, which is a transcutaneous administration. So there's no needle even, in fact. So you're getting the sound waves concentrated in an area at the target, and that heat is developed. But, there need to be refinements in all of these technologies. I think that some of them have, for example, the radiofrequency ablation, I like very much for these very large benign nodules, because you can deliver a lot of energy very quickly and move through the nodule to get a great result. With laser, you have to put 2 fibers into the nodule, and you have to work with that, and it's a little bit more difficult to achieve a significant volume reduction for bigger nodules. But I would say that maybe for small thyroid cancers, we'd have to compare laser versus RFA. I think that maybe that would be an interesting study. And I know some of my colleagues throughout the world and here in the United States are interested in doing something like that. I really think alcohol itself has now become sort of a primitive modality. I'm not saying that I wouldn't use it at all. Alcohol is very good if you have a benign cyst, and that cyst is filled with, obviously fluid. You can extract it and put the alcohol in. It's much cheaper than any of the other things that we've talked about as RFA or laser. And that usually is enough to get a cyst to actually compress and not come back. But I wouldn't use alcohol for any of these other things that we talked about today so far. I think microwave is interesting, but what happens with microwave is you deliver a lot of energy very quickly. You don't get any feedback about like what's happening to the tissue. And by the time you see it on imaging, unless you're, really savvy about it, your ablation zone can migrate past where you want to. And then by that time, it's too late and you can have problems. So I think there need to be refinements in all of these technologies. Heck, RFA, we're talking about it as this is it, like this is the great thing. And it's good, but it can be better, right? We have to have it easier. We needed to make it more accessible for the patients. More people should be able to adopt it, more physicians. We need to know where the appropriate important structures are. Maybe the probe while we're in there will tell us you're too close to a nerve and it won't turn on. It'll tell us you're definitely in thyroid tissue. And so, yes, you can turn on, but hey, you happen to have your needle outside of thyroid tissue and we're not going to let you turn it on. Or maybe it becomes as easy as having a software algorithm where you just press a button and then you're talking with the physician and you're having, just a conversation. I mean, this is all going to evolve. This is very nascent. This is like the beginning of it all. But I bet you in 10 years, we look back at this and we should pull up this seminar and go, what were we talking about back then? It seems so primitive, archaic. I think this is going to evolve very quickly.
Indeed, it's a very exciting topic for us to be even just able to live through this time that we're having these procedures available to us. I will say for the viewers, I do have a couple of interviews available on my channel about laser ablation, and upcoming in the near future, I have an interview with a provider of microwave ablation. So if you want to find the link to view those, go visit the Save Your Thyroid booth in the platform of the conference, and you'll see the link to my channel. It's me, Jen, again there. I actually have a question now for Jody. Someone is asking, do you still have your nodule? Is it just smaller or has it completely disappeared?
Yeah, so it's gradually gotten smaller. It was, much bigger for at least a year. And then now it's like quite tiny and still shrinking. So, yep. Mm-hmm. Actually, the tech was like, where is it? And then she left, and then she came back, and she's like, we're all having trouble measuring it. So it was good.
Wonderful. Dr. Tufano, can you talk about why initially after treatment, a nodule may appear larger than it initially was because of the treatment outside of the boundaries of the nodule?
Yeah, just think about it. So you have your nodule already, and this time, unlike a benign nodule, we're concerned about the thyroid cancer, the margin, right? So we want to go a little bit more into the normal tissue to create an ablation zone around that to ensure that we have a little bit of a margin. And it doesn't have to be excessive, but at least a few millimeters beyond what we can see as the margin. There's also blood vessels that we're going to treat at that area too that are important to ablate so that the regrowth doesn't happen, so it doesn't stay viable. And again, when you treat this area, what you're going to see is that just like anything else, when there's an injury to the body, there's swelling. And so there's something called edema, which is where the proteins are denatured, the fluid accumulates, and you get some initial swelling. So in the first few months after RFA for these small thyroid cancers, this is not an uncommon scenario to see what Jody went through. And then you start to see, this remarkable sort of contraction of the nodule. And more often than not, it may get to a point where you're not going to be able to see it at all on ultrasound. But sometimes there's some residua and it may be scar at that point in time. I don't think that we are inclined to do or need to do a biopsy to trouble the patient. I think if we have the ultrasound, we follow the ultrasound. You're going to follow it with ultrasound, whether you had active surveillance as an option or chose that, surgery as an option, or RFA. And I think that's fine to do and see what happens from there.
Thank you. And we have a few questions also in the comments about who is performing procedures at Mayo. I'll let you know that in our Facebook community, we do keep a list of known providers in the US and across the world. So visit the Save Your Thyroid booth and click the link there to join. And those lists are located in the file section at the top of the group. We have a question. What is the future for these procedures for Bethesda 4 nodules? Or I'm sorry, is that VI? So that would be 5, or I'm sorry, 6, right?
Which one is it?
Bethesda VI.
Yeah, I guess they're saying 6, but did they
6.
mean 4? Because that's what we're talking about. We're talking about Bethesda 6 nodules and Bethesda 5. Yeah.
This patient had a partial thyroidectomy for PTC, 1 4 millimeter positive lymph node, and a Bethesda 4 7 millimeter nodule on the other side, not tolerating thyroid meds, and can't imagine life with, I'm assuming, without the thyroid. This is a very specific question, so I'm not sure how much you can comment on that, Dr. Tufano.
Yeah, it's hard to say. I think that if, we are talking about papillary thyroid cancer, this seems like this patient had papillary thyroid cancer with a 4 millimeter positive lymph node. And then there's also a contralateral or other side papillary thyroid cancer as well. And then I think they're trying to figure out what to do with it. One point is I'm not sure you can really appreciate a 4 millimeter lymph node being positive for sure on ultrasound unless you took it out or biopsied it. Maybe it was biopsied. That's awfully small to biopsy, but it may have been. These are tough situations, and this is where you have to also look at the position within the thyroid, and you have somebody who's scrutinizing the lymph nodes. And this is still small volume disease. And if this is a younger patient, it has an excellent prognosis regardless. So, you could say that in this situation, the patient's choice is really important, right? We have to honor that. If they say, well, I have these little tiny sub-centimeter papillary thyroid cancers in my thyroid, and I have this one little lymph node that they think or suspect is papillary thyroid cancer, can we watch this? Can we RFA it? Should I have surgery? This is a very detailed discussion about pros and cons. And if it comes down to thyroid hormone and that's all it is, that's a tough one, right? Because all you have is trying to keep your thyroid if you want to not have to take thyroid hormone. But if there are other things that are concerning, maybe an education about that a little bit more to understand, may allay some of the fears and make it a little easier to choose one or the other. So yes, very complex, but these are the detailed discussions that you have when you go to a team that deals with only this and is current on all of the possible treatments for a thyroid cancer or a suspected thyroid cancer. Like you said before, Jen, if that surgeon doesn't happen to do RFA, or they don't happen to do a specific type of surgery like scarless surgery, and they only know what they know and what they do, then they may be dismissive of something else because one, they may not want you to go somewhere else. They may not want to lose that case, or they may not want to lose their endocrinologist referrals. So you have to think about this, and you have to do your own research, and you have to pursue sort of options that you think are going to be helpful to you and at least hear you out and talk about, I would really like this. Is this a good option for me? And somebody who's expert in it can tell you yes or no. And that's what you need.
Definitely. Absolutely. I always recommend the patients get multiple providers' opinions because it's really good to have different perspectives and even different multidisciplinary physicians on your team with different perspectives from their specialties. So always good to have lots of different information so you can weigh out all the pros and cons.
Yeah.
And we have a question about cancer returning after a thyroidectomy, a total thyroidectomy. This is possible and does happen quite a bit, doesn't it, Dr. Tufano?
Yeah, so we have to have a perspective on this as well. Papillary thyroid cancer goes to lymph nodes. And what do we worry about? I worry about big, bulky lymph nodes. Those are the ones that are going to be troubling. If they're bigger than 3 centimeters, if there's more than 5, if they happen to look like they're spreading into the surrounding tissue on our imaging studies, those are big, bad, worrisome lymph nodes, and they affect our prognosis. These small lymph nodes, whether we take out the lymph nodes at the time of surgery and we find a lymph node and it's small, or it shows up after thyroidectomy, whether you get radioactive iodine or not, if these are small little sub-centimeter lymph nodes, they tend not to affect your prognosis from a survival standpoint. They are very troubling because we follow patients so closely, so we detect them very early, and you think, oh my God, it's back. But it probably was there from the beginning. So if we can calm ourselves, again, we may have the option to just watch it. We may have the option for radiofrequency or an ablative therapy in certain select circumstances. And if it's just too overwhelming for you to think about any of that, and you need to have it out, then go find yourself a very experienced surgeon who does reoperative surgery and is very comfortable doing that, is known for doing that. And they can make that surgery as successful as an initial surgery, same outcomes, and with an excellent result. So you just got to find the right person, again, for all of this. Very important, but yes, this does happen. I think sometimes we just get so worked up about it that all we can think of is bad news, or this is just bad. It may be that your ultrasonographer or your endocrinologist is much better at doing the ultrasound and finding these things than if you went somewhere else. So don't get too worked up about something small that pops up. I mean, it doesn't have to be stop the presses. You need to do something today, and then you go and have something done by somebody who's not so experienced, and you're going to regret that because you're going to live with those consequences the rest of your life, because you're going to have the rest of your life in front of you, even with that small papillary thyroid cancer metastasis.
Absolutely. I think it's very important to think long-term and to have this idea of, just not thinking immediately about, as you said, just reactively treating it, but thinking long-term. Now, if there's a patient who has something that pops up very quickly and grows very rapidly, that's a different story than if you have something that pops up a year or two later and it's very, very small and it's very slow growing. So it's good to keep all of that in mind as you're evaluating all of these things. And as you said, to have a team that is very high volume and experienced. Unfortunately, I think we've discussed this in a previous conversation. Volume is key, and low volume surgeons can sometimes have bad outcomes. So you want to have a surgeon who has a great deal of experience, and the same with the RFA or any other thermal ablation technique. They need to have that experience and training to make sure that you're getting the best possible care. I think we have made it through all of the questions. Let's see, someone is asking about the Facebook group. The link is the link not working on the Facebook group for the booth? If it's not working, just search on Save Your Thyroid on Facebook and you should be able to find it that way. Or if you go to my channel on YouTube, all of the links that I have are in the descriptions of all of the videos. Thank you. Okay. Does anyone have any other questions before we wrap up the session? And while we're waiting on any of those to come in, I would just like to encourage everyone here to visit a couple of different websites. One of them is NASIT.org, NASIT.org. That is the North American Society of Interventional Thyroidology. And that is an organization comprised of multidisciplinary physicians who are all working towards developing more of this thermal ablation techniques in the United States. And then also another organization, NASOI, NASOIE.com, is the same sort of organization related to endocrinologists. Both of these organizations are really working hard to get more providers on board with these thermal ablation techniques. And then also don't forget to join the Save Your Thyroid community if you're looking for resources and patient testimonials like you've heard today in this webinar. Let's see, any more questions?
I think Em had a question.
Yes. Someone is asking the smallest size of a nodule that can be treated with RFA.
So you have to be able to see it on ultrasound. Ultrasound keeps getting better and better. And I think that there's still improvements to come. You can probably reconcile a 4 to 5 millimeter nodule and stick a needle in it and determine whether it's thyroid cancer or not. Should you do that? We heard about this before, right? In the NHS, it doesn't make sense because it's not cost effective. There's a limited amount of resources. So they say no. Then the incentive there is it's a disincentive. We're not going to pay you if you do that. Here in the United States, you still get paid if you do the procedure, but that's why it doesn't happen in the NHS. So can you find a small nodule as small as 4 or 5 millimeters? Yes. Can you target it for biopsy? Yes. Could you target it then for RFA? Yes. Should you do it? Probably not. So once you put a needle in it and you know it's thyroid cancer, now you're kind of like stuck, right? Because it depends on the person. They may go, oh my God, I got to get this out tomorrow. I got to get it treated tomorrow. Or another person may be like, you're not touching me. Nobody's touching me. I'll see you in a year. We'll see what it does. I got a lot of other stuff going on, right? Depends on the person.
Can you touch a little bit on the standards we have here in the US? And Em mentioned this in the video about biopsies under 1 centimeter, what that cutoff has to do with why we don't typically biopsy anything under 1 centimeter.
Yeah, there's a lot of data out there and more coming from different populations, but out from our Japanese and our Korean colleagues, obviously a more homogeneous patient population. So do you say, well, does that necessarily absolutely relate to the US population? Maybe yes, maybe no, we have to check. And so even some of the work done here in the US, we know that these papillary thyroid cancers that are less than 1 centimeter, without any association with any other concerning features, no strong family history, no ionizing radiation exposure, no lymph node metastasis on your ultrasound, that they hardly do anything. Over a 10-year period of time, they might not grow more than 3 millimeters. In fact, the overwhelming majority, only about 10% will grow more than 3 millimeters, and less than that, in fact, will have a lymph node metastasis. The problem is here in the United States, thyroid treatments, surgery especially, gets done by surgeons who do 5 or less a year, the majority of them. So what happens to that patient who has a small little tiny thyroid cancer? They get a surgery. They get a total thyroidectomy. Then they get radioactive iodine for a cancer that probably would have never manifested in their lifetime. That would never have become obvious. And then not only that, if it's done by a surgeon who doesn't do it all the time, and let's say it's a 27-year-old woman, she lives with hoarseness the rest of her life. She may be hypopara and take calcium and vitamin D the rest of her life. And in fact, Thyroid cancer has one of the highest bankruptcy rates associated with it compared to all the other cancers. Why? Because people live with thyroid cancer. They're dying of other bad cancers, but
Right.
the costs of having to be on thyroid hormone, the costs psychologically, emotionally, distracting from your workforce and work, hypoparathyroidism and taking calcium supplements and vitamin D and the consequences, it's real. So unless you can, I mean, you may say then, because there's a question, why not a 4 mm nodule? Why not? Why wouldn't you want to know? I think that in an ideal world, we would love to know, but the consequences are such that it can be actually much more damning than helpful.
That was a very good explanation about that. Thank you so much for kind of elaborating on that. Let's see, we have a couple more. The last question in the chat, not for MTC. What if you don't know you have medullary on the initial FNA, it showed papillary?
You should know on the final aspiration biopsy specifically what you're dealing with. Usually papillary thyroid cancer is not a difficult diagnosis by final aspiration biopsy. Medullary thyroid cancer as well, these cells look very different than your typical thyroid cells or the cells that where papillary thyroid cancer comes from. And typically there's other laboratory testing that can help us as well. So medullary thyroid cancer is a much more aggressive thyroid cancer. It has the chance to be bilateral. We typically see it in lymph nodes, and when it is in lymph nodes, it has a poorer prognostic association. So different animal. So we cannot put medullary thyroid cancer. It's only mentioned in this conversation to exclude it. So we're not thinking about RFA for a new medullary thyroid cancer diagnosis. With that being said, if a patient has had 6 surgeries, they present with a medullary thyroid cancer lymph node. That's the only thing they have. Surgery doesn't seem like a good idea. They're tired of it. Their calcitonin is still high. This is not going to be curative, but they just want it to go away. We can think about RFA. We're personalizing the care, but not as a primary intervention for medullary thyroid cancer. I'm one of the biggest proponents of RFA or any ablative therapy, but medullary thyroid cancer, just right now in 2022, cannot be considered.
Thank you for explaining that further. We did talk about that a good bit yesterday in our session. If anyone wants to go back and watch that previously recorded session 211, we talked a lot about palliative care for thyroid cancer recurrences. So it is the end of our time, so we need to close this session. But I again encourage you to visit the websites nascet.org, nasoy.com, Save Your Thyroid Community on Facebook. And thank you for joining us. Thank you, Dr. Tufano, for all of your insights. Thank you, Jody and Marina, for sharing your stories, and also for Em, who recorded hers with me previously. This has been a wonderful session, and I just really appreciate all of you very much. With that, we'll say goodbye and enjoy the remainder of the conference.
Great session. Thank you all. It was really enjoyable.
Take care.